Yousuf, I
So I
think
think
we
next is
can.
discussion with Dr. Ivana Roskova and Dr. Liew Boon.
Thank you so much. Can you hear me?
Yes.
Yes.
Thank you so much. My name is Ivana Roskova. I'm neurosurgeon from Czech Republic. I just want to quickly introduce myself. I'm so delighted to be part of this beautiful event. Thank you so much for all these excellent presentation. Thank you and congratulations to all of you. If there is no questions or if anyone wants to introduce, maybe Dr. Lee? Dr. Liew Seng, do you want to introduce yourself?
Yeah, my name is Liew. Liew is my surname. Boon Seng is my given name. I'm from Malaysia. I'm neurosurgeon. Thanks to all the three speakers for a very nice presentation. While we're waiting for the question, probably both of us can ask some question to our speaker. Is it okay, Ivan?
Yeah, it worked for me. Thank you so much. If I can talk first, I would like to ask some questions to our speakers about this presentation because I think it's super helpful for you, especially young neurosurgeon, to get some kind of tips and tricks. So I would like to ask Professor Ahmed Adnan about his selection, about if he's deciding between the Mayfield and the Sujita. You told us that the Sujita is your favorite holder, but are you going for the Sujita even if there is some kind of, patient is after the craniotomy or decompressive craniotomy of cranioplasty? Are you still choosing the Sujita preferable to Mayfield holder?
Yes, you know that the Sujita for me, I cannot generalize this rule, but for me, I have some engineering inclination basically before neurosurgery. So for me, the Sujita probably is safer than the Mayfield.
Okay.
And the FDA augments my opinion because there is no reportable incidence of slippage or breakage in the arc in the head frame of the Sujita. While in my lab, I'm also the director of a lab in cadaveric lab. I have two Mayfields that they have a break. Perhaps the cadavers are more stiff, so the incidence of breakage probably is more. This is number one because in my hands the Sujita is safer than the Mayfield. Number two, the in Sujita you can use up to 6 pins, so you can reduce the pressure per pin. While in Mayfield, you are, of course, obliged only on 3 points of fixation. In Sujita, you can use 6. Usually, I use 3, just like the Mayfield. The less invasion on the scalp, the less probability of vascular and nerve injury. But sometimes you need to use 4 pins. This is mandatory in children. Even in adults, sometimes you need to reduce the pressure per point. For example, when there is a skull problem, and this option is provided with Sujita, not with the Mayfield. In the case of rapidity of insertion, it's the same. You can insert the Sujita in less than 1 minute, and you can, of course, insert the Mayfield in less than 1 minute. I heard from my Egyptian colleagues that they have some difficulties in inserting the Sujita. I think it needs some learning curve, and it needs some trick how to hold it. It needs two persons. The most important point or disadvantage of Sujita, the head has to be floated while you are inserting the Sujita. While in Mayfield, you can insert the Mayfield while the patient's head is resting on the table. While in Sujita, you have to bring the head outside the operating table, floating in the air, and your assistant should hold the head from front, and then you fix the Sujita system. This probably makes the Sujita rather tricky to use, but I prefer it in summary because there is more safety in Sujita, there are more options of pins, and it is universal. And at the end of the day, it's a matter of preference. I have both systems, I use both systems, but more I'm inclined towards Sujita for these reasons that I mentioned to you.
Okay, thank you so much. And my additional question actually to the pins holder was, you mentioned that you are using, like for the kids, for pediatric neurosurgery, you are using the smaller pins. How you can Because sometimes, it happens, we have some kind of complication about CSF leak, but of course the epidural hematoma is like less common, but it can occur. So do you have some kind of tips and tricks for young neurosurgeon, how they can avoid and how they can maybe totally remove this kind of complication from...
Very important question. Yeah. First, you have to choose the correct pin. Don't use adult pin in pediatric patients. Second, you have to measure the thickness of the skull per CT scan. You can use Boon study and you can measure the thickness and you can choose, because there are variations. Probably you will have a lacunae somewhere that you will enter immediately into a venous lacunae. So you have to study the CT scan of the patient. You have to measure the thickness of the skull. So first one, use the correct pin, whether you are using the Sujita, use the pediatric, whether you are using Mayfield, use the pediatric pin. Second, you choose the proper bone based on individual anatomy of the patient. Third point, avoid excessive pressure, because we have the most frightened complication of head slippage. Probably some of us unconsciously will exert more pressure per pin. This is wrong. You have a limitation of pressure. If you are dealing in less than 2 years, of course, less than 1 year is not suitable for Mayfield. You can use Sujita, but you cannot use Mayfield. Don't exceed more than 20 pounds. If you are between 2 and 5, don't exceed more than 40 pounds. Okay? After the fixation, you have to check the head stability. If the pin is penetrating the skull more than usual, then you will have inversely counterintuitive. You have the head that is unstable. So these are the points of precautions. I will summarize because this is an important point. Choose the correct pin, measure the thickness of the skull, and choose the correct pressure, and check the head after your fixation. I hope I could answer your question.
Yeah, thank you so much. I think this is really useful tips and tricks, especially for all of us, not just for young neurosurgeon. Thank you. Dr. Liew, do you have any kind of questions you want to follow?
Yeah, probably we have some question for Nagiza. Thanks for a nice lecture. I would want to bring your attention to our traditional teaching on deciding size of craniotomy. We used to have 1 centimeter for the dura from the edge of the tumor, for example, and 1 centimeter for the bone opening, and 1 centimeter for the scalp opening, almost 3 centimeter radiusly. And I think with the minimal invasive, I know you didn't talk about minimal invasive, that kind of concept are not so relevant at this era, especially with the IGS system. What is your comment? Thank you.
I think why I didn't put minimal invasive approach, any explanation about that, because any minimal invasive approach, as per my opinion, requires one of the best and good neuroanatomy knowledge. And being a young neurosurgeon going directly for minimal invasive approach, it's quite difficult. And again, it's not only about young or not young neurosurgeon, it's probably mostly, it depends on the size of the tumor. If you think that a big approach will benefit the patient, it will not create too many complications, so you can go for the bigger approach. But I know some centers and some countries are staying strictly to the philosophy of going towards the minimal invasive, and it depends on the equipment, it depends on the your technologies, maybe some financial things of the hospital. So, but classical approach for young neurosurgeons should be, at least we should know, in case we won't be able to go for minimal invasive, we should know the standard procedures, and standards are always standing along with the knowing anatomy of superior sagittal sinus, transverse sinus, sigmoid sinus, as well as all sutures, and with the respect of bridging veins, of course. This is also, I haven't mentioned, but bridging veins is something which we have to know, especially going into interhemispheric approaches.
Yes, thank you. Probably one additional question on craniotomies, and it was traditionally we have been taught that what have been open need to be closed. So the craniotomy is just a path for us to reach our target, to do our job, and we must do a proper closure for every layers. What's your opinion regarding this? And also probably including the role of keeping bone dust in neurosurgery. Thank you.
Again, regarding the bone dust, when I was training in one country, people used to remove bone dust because it can be the source of infection. In another country, it can be easily put back. Regarding the opening and closing, yes, in order to avoid a frost watertight dural closure, this is what will give us maybe not even the craniotomy opening and closing, but the dura. This is something which we have to take care of. Sometimes going for craniectomy, I know that in some cases for CP angle tumors, people just go for craniectomy and they don't need to put that small part of the bone around the asterion and transverse and sigmoid sinus. So as if you can to close it in a good way, in standard way, maybe with good again equipment, so special clips, special screws, you should go for it. But some hospitals and countries opportunities, so you have to tighten it with suture material, which sometimes can be loose. And but I think yes, it should be as it was opened, it should be closed. I think maybe if masters are not agree with me, but as young neurosurgeons, we have to understand whatever you opened, you have to close in the proper way.
Thank you. Hopefully, we have some expert here in our panelists or in our screen now. If any of the experts want to give their opinion, Professor Jack or Professor Salman.
Sorry, I think we are just running short of time, so maybe we can discuss it in the group, but in the interest of time, because many people are following, so we need to give them time. Excellent sessions. You guys did a great job. I think we have Abu Zar now doing a legend talk. Yeah.